I will try to cover a very broad area of deep brain stimulation, and really it's a lot to cover in the next 25 or 30 minutes. But I will try to give you a broad idea of the newer things also, and plus the basic things of how to do a DBS procedure. My aim is to demystify it and to present it in a very simple fashion so that it makes sense to most of us. Do let me know if my slides are not advancing or if you don't see my videos. Please do let me know. So DBS is a very exciting field of work, and what we know is that the commonest indications so far are the movement disorders. These are movement disorders which are not responding to medications, and therefore, at the very start of when movement disorder surgery began as lesioning, really these were the indications to offer surgical treatments to these patients who could not be benefited by medication. So Parkinson's disease by far is the single most commonest indication of deep brain stimulation, followed by dystonia and essential tremors. So apart from movement disorders, the other two common indications for deep brain stimulation are neuropsychiatric disorders, specifically OCD, and also intractable epilepsy. There are new indications that are being explored and innovated, and really this is a very exciting field to be in. And in the other thing which really attracts me to this field is that you could really make a huge change to somebody's quality of life. Now, interestingly, the discovery of deep brain stimulation was actually by chance. So, Professor Benabid in Grenoble in France, what happened is he was actually doing a thalamotomy procedure. And when he inserted the thalamotomy lesioning electrode, his chance finding was that high frequency stimulation of this electrode itself was able to abolish the tremor. So that got him thinking that really does one need to create a lesion, or is there a way to create a functional lesion without actually anatomically lesioning the brain tissue? Uh, this, of course, started and gave us the whole new field of deep brain stimulation, in which we do not actually lesion a brain tissue, but we stimulate it at high frequency, and thereby we produce a functional lesion. Now, DBS, sadly, one of the problems in implementing it more widely is that the awareness of this technique is not very high. Even in India and even in the major cities, there will be physicians and neurologists who may not be aware, and neurosurgeons who may not be aware. And if a patient approaches them for this kind of a treatment, they might say that this is something like an experimental treatment. So DBS really is a very well established treatment, and it has a large amount of animal work and primate work and human work that has gone before this chance discovery of the efficacy by Professor Benabid. Neurostimulation, as you know, is an approved indication, is an approved technology which can be employed for movement disorders, epilepsy, and psychiatric disorders. So there is an FDA approval for almost all these disease entities if you want to use deep brain stimulation. But of course, the criteria are very, very specific. Now, in the past, specifically, I would say in the past 3 decades, there has been a shift from doing more of lesioning surgery to doing more of deep brain stimulation surgery. Uh, as we speak, lesioning is making a comeback because now there is a non-invasive method of doing lesioning using the focused ultrasound with MRI guidance. But in general, the advantage of lesioning is that it is very quick, it's inexpensive, and it does not need any much of follow-up or resetting of the parameters. The huge drawback is that you cannot do lesioning bilaterally. If you want to do lesioning bilaterally, you are looking at a small but a definite risk of irreversible side effects. So the main advantage of deep brain stimulation is, firstly, it is reversible. Secondly, it is customizable to a particular patient. For example, if you have a Parkinson patient who has more of rigidity, then you can use certain programming parameters after you do the DBS surgery. If the Parkinson disease patient has more of tremor, then really you need to increase the frequency of your stimulation and the tremor will respond to that. So what I'm trying to say is the elegant point about deep brain stimulation is that you can customize the technology to a particular patient depending on what the primary problem that the patient is having. And it is reversible and it can be done bilaterally very safely. So these are the three reasons because of which the deep brain stimulation has become very popular. And in fact, it is the procedure of choice for treatment of advanced Parkinson's disease and really the other movement disorders once they are refractory to medical treatment. Now, interestingly, we do not fully know the mechanism of action of deep brain stimulation. I did mention to you that high frequency stimulation is what we use in all our applications of deep brain stimulation. And actually, we call it deep brain stimulation, but we are actually inhibiting the target into which we insert the electrode. So high frequency stimulation acts like a functional lesion, and it actually inhibits the function of the nucleus or the structure or the area in which you are inserting the electrode. Deep brain stimulation likely has at least three mechanisms of action. One, of course, is the action on the particular circuit itself. So, as I told you, it inhibits that particular nucleus. Secondly, it has an effect in up or down regulating the levels of certain neurotransmitters in that area. And thirdly, it does have some effects on the local blood flow. So the effects on the local blood flow are well documented if you do perfusion and cerebral blood flow studies in patients who have had deep brain stimulation. Now, getting down to the fundamentals of deep brain stimulation. So DBS is nothing but implantation of a stimulating electrode in a deep target inside the brain. We talk about deep brain stimulation as if it is a single procedure or a single kind of procedure, but really there is a variability in how DBS is done across the world. For the large part, DBS is a bilateral procedure. As I just mentioned, one of the advantages of DBS is that you can do it bilaterally very, very safely in distinction to lesioning. DBS is, for the most part, a frame-based procedure. There are some institutions which are employing robots and which are employing frameless methods to do DBS, but those are really very, very few institutions. For most of us, DBS is a frame-based stereotactic procedure. And what I still do is the classic DBS surgery in which we use microelectrode recording. So first we insert the microelectrodes and you identify electrically the area of the brain into which you want to finally insert the stimulating electrode. Again, as I said, I do a classic DBS operation in which the patient is awake. And I'm talking now about the Parkinson's disease deep brain stimulation. As you know, patients who have epilepsy or who have dystonia, we cannot do most of these patients awake. We can do some of those awake, but patients who have a very severe dystonia, you would not be able to do a big procedure on them for obvious reasons. And of course, the last part of the surgery is always done under general anesthesia, which is the implantation of the pacemaker. Now, the next question which comes up is which target to use. So the targets are pretty well defined depending on the indication or condition that you are treating. Here on this slide, I'm largely talking about movement disorders. So when you talk about movement disorders, so for Parkinson's disease, most of us use subthalamic nucleus. There are some groups across the world which say that globus pallidus is an equally good target even for Parkinson's disease, which may well be true. But I do believe, and the literature also supports the view, that subthalamic nucleus is superior as a target for Parkinson's disease compared to GPI. Now, globus pallidus is the main target when you want to treat a patient with dystonia. And I will probably show you an example of a patient. And globus pallidus really is not difficult to target at all. And the third common target for movement disorders is thalamus. Now, we target the thalamus when we are treating a patient with tremor. So, patients with essential tremors, post-stroke tremors, and other kind of tremor disorders, the thalamic target which we usually choose is the VIM, or the ventral intermediolateral nucleus of the thalamus. Now, the success of a DBS procedure depends really on many, many factors. And as surgeons, we are just one part of the team which will be managing this patient to get a good outcome. So the first and the most important thing is the correct selection of the patient. Now, the correct selection of the patient is a very, very important criteria. And here comes the importance of a collaboration with a movement disorder neurologist. So I'm lucky to work with excellent movement disorder neurologists for the past 25 years. And therefore, I have absolutely no doubt or worry whenever I'm selecting a patient with Parkinson's disease, because they are looked at by very, very experienced movement disorder neurologists. And the commonest mistake you could do is to select a patient with Parkinson's disease who does not have the idiopathic Parkinson's disease, or a patient who has something that looks like Parkinson's. So it's very important to select the correct patient. And the second thing, and this, if you notice this slide could actually just be labeled as the general principles of surgery. So the correct patient, the surgery has to be done at the correct timing, and of course you need the correct team to be involved with the patient. And then of course is the very, very important part, that the surgical procedure should be done well. And then after that, the post-op medical management of the patient and the stimulation management of the patient. I think these are all equally and very, very important components of how you would like to achieve a good outcome for your DBS patient. So the correct patient selection, and here I am taking Parkinson's disease as the typical example. What you need to select is the classic idiopathic Parkinson's disease, not the Parkinson plus syndromes, not the vascular Parkinsonism, not entities which can really very closely mimic Parkinson's disease, such as the PSP-P type and the MSA-P type. So it actually needs a movement disorder neurologist to pick up the red flags and tell you that, this is not a Parkinson disease patient. For example, a Parkinson disease patient who is having autonomic dysfunction within the first 5 years is a red flag. Somebody who's having very obvious eye signs within the first 5 years of Parkinson disease is a red flag. Somebody who is developing gross ataxia within the first 5 years of having Parkinson's disease. So these are all red flags which tell us that this patient may not actually be a patient with idiopathic Parkinson's disease. Now, in Parkinson's disease, you see the typical phenomena that as time passes by and the patient progresses to what we call as an advanced Parkinson's disease, what happens is that their medication effect really gets squeezed in time. So a patient who was taking, let's say, 2 tablets of Cinemet in a day, and each tablet was giving him or her 12 hours of relief, over time finds that the relief has been squeezed down to just 2 or 3 hours. And as a result, the patient has to take these medications 4 times a day, 5 times a day, and so on. This is a typical example of what we call as an on-off phenomena or a motor fluctuation. So a very, very good way to screen patients who could be candidates for deep brain stimulation is to use this Delphi 521 criteria. So any patient of Parkinson's disease who needs more than 5 levodopa tablets per day, and despite the best medical management is having 2 hours of off phase in a day or 1 hour of troublesome dyskinesias in a day, is a candidate to be evaluated for deep brain stimulation. I'm not saying this patient should be offered DBS, but this patient should be evaluated for DBS because there are now newer drugs available. And if initially such a patient was being managed by a neurologist, then maybe it is time for this patient to be seen by a movement disorder neurologist and maybe try a different drug combination. And from then, you could then select the actual good candidates for DBS surgery. Now, sadly, what we are finding is the patients we are still getting are being referred to us very, very late in the course of their disease. And at that time, they have a lot of psychosocial impairment, and they are in their late 60s and 70s, and they have some comorbidities which could actually prevent them from being good surgical candidates. So they may not be surgically fit to take up for a surgical procedure. All of us know about this very interesting and very important study published more than 10 years ago, in which they followed very clear criteria for labeling a patient as having early motor complications. And what this randomized trial found very clearly is that the patients that were offered neurostimulation, they had a huge positive impact on their quality of life. And you can see all the metrics on this graph, including mobility, activities of daily living, emotional well-being, bodily discomfort, cognitive function, communication. So all the important things which matter to the quality of life, the patients that were offered neurostimulation, meaning deep brain stimulation, did significantly better than those with the best medical management. So the message here being that the patients have to be selected as soon as they step into what can be called as advanced Parkinson disease, as soon as they step into when they have the criteria which applies to them, which I mentioned just now, which is the 521 criteria, they should be offered deep brain stimulation at that time. What is actually happening is that many of the neurologists are waiting for 10 years and 15 years with a huge amount of disability which these patients have, and they are being offered deep brain stimulation as a last resort. So that is not the correct time to offer DBS to these patients. Now, these patients need to be managed by an appropriate team, and the team should have a movement disorder specialist or at least a neurologist who has some interest in movement disorders. There should be a neurosurgeon who is well versed with stereotactic procedures. And of course, you need the anesthesiologist, you need to have a good ICU, you need to have an electrophysiologist, you need to have a good radiology backup. With this team and infrastructure, the other important thing is to have a good teamwork and the division of roles and responsibilities between the neurologist and the neurosurgeon. So some of the programs they face a problem because the roles are not defined, or you are really going into each other roles. So, for example, what we do very clearly is that my neurologist does not have any role in the surgical procedure, including the target selection and the target planning. And I don't have any role in the stimulation management or the medical management of the patient. So our areas of work are very, very clearly defined. We have clear protocols as to how we will manage a patient who is having deep brain stimulation surgery. And so that there is no communication gap, there is no misunderstanding. And ideally speaking, I would call a DBS center as a center which is doing at least a DBS procedure in a month. So I would say for a center which is hoping to start, should reach this number of 10 or 12 cases in a year. And once you're doing a case every month, that is a good volume so that your surgical skills, expertise, the team coordination, the protocols, all of them will fall into place. If you are doing less than one DBS in a month, then really what happens is that the people are not too much in the habit of uh, following all the protocols, and you could kind of face challenges. I would say the aim would be to hit this number of 10 to 12 cases in a year. And then once you're doing regularly, at least one case every month, then definitely you would be a good volume DBS center. Uh, so the surgical procedure itself, now let me discuss some of that in some detail. So these are the various steps of a DBS surgical procedure. And I will try to show you very, very brief videos of each of these steps, which should be self-explanatory. But of course, I would be very happy to answer if you have any questions related to any of the steps. So the imaging part, we will talk in some time, but let me show you a brief video of frame fixation. So what I do is I fix the frame with the patient in a sitting position and with the assistant stabilizing the frame. You will also notice that we have earplugs inserted into the ear on both the ends. That really is very helpful because it reduces the displacement along two of the three possible displacements which could be there. And the third, which is the ACPC axis, what we actually follow is that the orbitomeatal line should be parallel to the base of the frame. That is something which is very important. Frame should be optimally tight. It should not be over tight. If you over tighten the frame, then over a period of time, the quality of the frame gets impacted. Patient has to be kept comfortable, so a good dose of local anesthetic into each of these areas into which we will inject and then put these pins is very important. Typically, what I tell the patient is to breathe deeply, and also very important for the anesthesiologist to be around in case there is still a lot of pain. maybe a very mild dose of sedation can be given to make the patient more comfortable. Some people apply the frame in the supine position, which is also fine. But really, you saw the frame being applied almost in real time. And actually, it takes all of 2 to 3 minutes to apply a frame very rapidly and very comfortably for the patient. Now, imaging. So, imaging, what we follow these days is that we do a non-stereotactic MRI a few days before the procedure. And on the day of the procedure, we just do a stereotactic CT. Now, this is from one of my earliest cases in which actually I used a ventriculography. And these arrows are pointing to the anterior commissure and the posterior commissure. And in fact, if you notice, there are these readings on the frame. So actually, in that time, which is about almost 20-25 years ago, what we actually used to do is to calculate and get the X, Y, and Z values directly from the frame from an X-ray image. Now, what we do these days is use the MRI, and really the MRI is very important because it shows you the subthalamic nucleus directly. And what you're doing by taking MRI as the important image for the target planning is that you are using the patient's own anatomy. Now, subthalamic nucleus is a very small nucleus if you look at these figures. And if you just look at the figure, the anterior-posterior and the mediolateral diameter and the dorsolateral diameter are more or less 4 to 5 millimeters each. So you're actually targeting a very, very small nucleus deep inside the brain. And more importantly, the size and the location of this nucleus is very variable between different individuals. Paper shows you that there is a lot of variability in the position and the size of the STN. And that is why it is very important to target the patient's own anatomy. Now, what we do, as I told you, is that we after putting the frame, we apply this indicator box on the head of the patient on the frame, and then we just do a very quick stereotactic CT. Now, and then what we do is we fuse the stereotactic CT images with the MRI images that were acquired a few days before. Some institutions, they do a stereotactic MRI. So they put a frame on the patient on the day of surgery, and then they put the patient in an MRI machine. Now, that is also an equally good option, but it is an option which is not very, very comfortable for the patient. Because you can imagine patient with a frame on, and that frame then fits inside an MRI head coil. It does not go inside a generic MRI head coil. You need a special large head coil to accommodate the frame. And if with that, it could easily take you 35-40 minutes to acquire all the sequences in the MRI. So mostly what people use is a stereotactic CT fused with a non-stereotactic MRI images. Now, MRI imaging, the couple of image sequences which are kind of mandatory are the 3D T1 image taken with contrast, and I'll tell you why that is so in a minute. And the important MRI image in which actually you see the subthalamic nucleus is a very high quality T2 weighted image. Now, if you look at the image here, and if you see my cursor, it is pointing to the subthalamic nucleus in the coronal image on both the sides. If you see this red line and you see this green line, the point at which they stop are the subthalamic nuclei on both the sides. And below the subthalamic nuclei and medial to them is the red nucleus. Again, in a very good quality T2 image, on the axial image, you can actually appreciate the red nucleus and also the subthalamic nucleus lying tangential to it. Now, whenever you are targeting for DBS, basically you have three methods available to you for targeting. So one is the older method in which you use the anterior commissure and posterior commissure and a line drawn between them, which is the ACPC line. And the midpoint of that is called as the mid-commissural point. So every standardized target, for example, the subthalamic nucleus, the GPI, the WIM, the traditional textbooks will give you an indirect coordinate which is based on the ACPC line. And that is derived from a surgical series or even a stereotactic atlas. So it is something which is indirectly derived. Now, the challenge with using indirectly derived coordinates is that you could be dealing with a patient with a very small head or a very large head. For DBS, you could be treating a 6 or an 8-year-old child with dystonia, or you could be treating a 50-year-old person with Parkinson's disease. So you cannot apply the same standardized targets to this heterogeneous group of people. So the better option is to use direct targeting wherever you can see the nucleus. So for subthalamic nucleus and for globus pallidus, it actually is very easy to locate them on the MRI image and to target them directly. The problem happens when you cannot directly see the nucleus. Then you have to go back to the indirect coordinates. Now, the third method of targeting is to use something as a landmark which is there in the vicinity. For subthalamic nucleus, red nucleus is a very, very important landmark. And actually, red nucleus based targeting has been shown to be very accurate for the subthalamic nucleus. Now, the red nucleus based derivation of the subthalamic nucleus is very simple. This is the red nuclei. And if you draw a tangent to the anterior surface of the red nuclei, that is the y coordinate of the subthalamic nucleus. And the x coordinate is simply taking 3 millimeters lateral to the lateral edge of the red nucleus. So in this fashion, you can very easily derive the XYZ values of the subthalamic nucleus by using these three methods. So in a given case, I actually use all the three methods to arrive at XYZ coordinates on both the sides. And then I see where is it pointing to, and that is how I select the final target. So in fact, in this paper by Professor Lozano's group in Canada, in fact, they have shown that the red nucleus derived target is actually the most accurate target. It's even more accurate than the directly derived. Now, going to something which is really very interesting and happening as we speak, we are including some newer MRI sequences in our target planning. So for example, the F-Gatter sequence, which I have shown you here, is a very, very important sequence. And why it is becoming so popular is that we can see the laminae between different nuclei. So if you look at this image, you can see the internal capsule, and between the globus pallidus externa and the globus pallidus interna, you can actually see this lamination. This kind of detail you can get by using these newer sequences. And if you look on the right side, there is an image called as the QSM, and you could actually mix a QSM sequence with the F-Gatter sequence and come up with a hybrid sequence which can delineate all these laminae very, very clearly. And this is, in fact, very helpful for targeting the globus pallidus for dystonia. High field MRI, for example, in this image, 7 Tesla MRI is already in human use experimentally. And I think within a year or two, you will have 7 Tesla images which you could fuse and target these nuclei much more accurately. And there are several other methods of targeting which are also being explored. Some, for example, using diffusion tensor imaging, and some using connectomics to target different parts of the nucleus. So we want to target the subthalamic nucleus for Parkinson disease, but the subthalamic nucleus itself has different parts. There is a motor part of it, there is a sensory part of it, and there is a limbic part of it. So it's very important to note that in the future, we will actually be able to functionally target the relevant part of a nucleus. Another common example, globus pallidus, as we know, is the preferred target for dystonia. But you know that for Tourette's disease and even for OCD, the anteromedial part of globus pallidus is also an important target. So what I'm trying to say is that we think of a target as a discrete point at which we must place the electrode, but each nucleus has different parts which have to be really targeted to get the best desired outcome. Now, once you're clear about the target, the next important thing is the trajectory. Uh, so, in the stereotactic technique, for example, if you have to take a biopsy, really it doesn't matter what trajectory you choose to reach the tumor and to take a small piece of tissue out of that. But in functional neurosurgery, the trajectory does make a lot of difference because you are placing a lead along the trajectory. And if the trajectory has some other functionally important regions which are also getting stimulated, then you could encounter stimulation induced side effects. So the important thing is apart from choosing the correct target, you have to use a very, very good trajectory to put the lead through to the target. And the important thing when you consider the trajectory is that it should not pass or it should not sort of damage any blood vessels. Otherwise, it could create a hematoma. So it should not pass through any sulcus because sulci will typically have a blood vessel inside it. It should not pass through the ventricle because if it does pass through the ventricle, you will have two problems. Either you could drain some CSF from the ventricle, in which case your entire coordinate system could get shifted, or you could then encounter a subependymal vein, which could rupture and produce hemorrhage. So stay clear of the sulci, stay clear of the ventricle. On the left side, stay far away from the caudate nucleus because if your lead is passing very close to the caudate nucleus on the left side, the patient could have speech disturbances post-operative. A couple of videos again. So this is the operation theater setup in which the patient is lying comfortably. So the important thing here is to make a semi-sitting position for the patient and spend a good 10-15 minutes to achieve a comfortable position, and the patient could lie in that position for 2 to 3 hours that it will take for you to put the leads on both the sides. And then after that, of course, you assemble the arc on the frame and then you make the burr hole and that's the burr hole. And once you make the burr hole, then what you want to do is you want to put some glue there to prevent any CSF leakage. And what you see in this video is that we have the 5-track recording system inserted into the burr hole. And once the dura has been opened, we put some glue so that the CSF, a lot of CSF does not drain away. One technical point here is that when you are doing DBS surgery, the burr hole should not be just orthogonal to the surface of the bone. You see, you have to assemble the micro drive and see how that drive, at what angle it is approaching the skull. So, for example, if you make orthogonal burr holes and your needle has to pass like this, it will hit the inner table of the skull. and you will not be able to exactly achieve the trajectory that you plan. So in a DBS surgery, very important to assemble the electrode array and then see what direction you should be cutting the bone so that these microelectrode can easily travel along that particular direction to the target. Microelectrode recording itself is very important, and this is the microelectrode recording setup. And we typically used to use 5 tracks, but now we've come down to 3 tracks. And in the diagram, you see the kind of recordings that you will get in a case of Parkinson's disease as you go from superficial to deep. And the subthalamic nucleus has a very characteristic recording which you see here in the diagram. And this is an actual recording with the audio signature. So this is the audio signature of a classic subthalamic nucleus recording. In this particular video, all the tracks are actually passing through the subthalamic nucleus. So if your targeting is good and the subthalamic nucleus being 5 millimeters by 5 millimeters by 4 millimeters in size, and your 5-track recording, there is a central electrode, and around it at 2 millimeter gap, you have the 4 electrodes, which we call as anterior, posterior, medial, and lateral. There are times in which all the 5 will show you a classic subthalamic nucleus recording, which means that your targeting is actually very good. Now, once you've made the bar hole, you have done the microelectrode recording, so you have an idea that you are in the correct place. Now, the important question is, does the electrode being in the correct place give you the desired benefit to your patient? Is something which we make out by doing an intraoperative assessment. And the intraoperative assessment is important for 2 reasons. One is that in a DBS procedure, what you're inserting as the electrode has 4 contact points. And the aim is of these 4 contact points, at least 3 should lie in the subthalamic nucleus, which you see here in green. So if they are in the subthalamic nucleus, once you stimulate, you will be able to get the desirable effect in your patient. And if your electrode is incorrectly placed, supposing this electrode is very medial, it is close to the red nucleus, then once you stimulate, you will have the corresponding side effects very clearly visible to you. For example, if the electrode is more posterior, then you will hit the medial lemniscus and the patient could have a paresthesia on the opposite side of the face or of the body. So it's very important to have a 3-dimensional orientation of the structure that you are targeting and the important nuclei that are surrounding it. So this is what intraoperative assessment looks like. So this is my colleague who is asking the patient to move the hands. And you notice the patient is not able to move the hands and the feet very well. Before the procedure. So when the patient is taken on the table, they are in a completely off phase. And that is why when my colleague is asking the patient to move the hands and to move the feet, the movements are very, very sluggish. And the electrode in, once you stimulate it, just see the speed of the movements. And this is a very good on-table verification that your lead is in the correct position. So this is what we call as testing for the desirable effects. Now, typically, when we keep the voltage as 1 volt or 2 volts, that is when we get the desirable effect. Or, for example, the current as 1 milliampere or 2 or 3 milliamperes. Now, the other important thing is you should hike up the current to 4 or 5 milliamperes to see if you get any undesirable side effects, such as face deviation or deviation of the eyes. If that happens, then that shows you that your lead may not be centrally within the subthalamic nucleus. It may be a bit more medial or more lateral, according to the kind of side effect that you get at stimulation of 4 milliamperes or 5 milliamperes. Another example of a patient with tremor, and as you stimulate on table, that you find that the tremor is completely disappearing. So as you turn up the stimulation, the tremor goes away. That again tells you that the lead is in the correct position. Finally, once you insert the lead on both the sides, uh, you use fluoroscopy as a guideline to check the vertical level of the lead, and you use one of the microelectrode as a guide to insert it to the correct depth. Stereotactically, we know the distance between the stereotactic stop and till the point that the electrode is going. But we always use fluoroscopy, and here you see the microelectrodes that are being used as a guide. And now you will see this electrode coming into view, which has 4 contact points, and we push it to exactly the desired depth using fluoroscopy. After doing this, what we additionally do is that we use an O-arm, and this O-arm scan is what shows us that the planned trajectory of the lead and the actual trajectory of the lead is exactly coinciding. So if you look at this video, the planned trajectory lead, which is in the colored lines, and the actual trajectory lead is, you can see, the artifacts of the actual lead, is exactly coinciding. So this O-arm scan is the next level of verification. So in DBS procedure, I think you can understand that the first level of verification is microelectrode recording. The second level of verification is checking for the desirable effect. The third level of verification is checking at high voltage for the undesirable effect. And finally is using the fluoroscopy to insert the lead to the correct depth. And the fifth is to use an O-arm scan to be absolutely sure that your trajectory and the point, the placement of the lead is exactly as per what you planned. After that, you anesthetize the patient, and basically you insert the pacemaker beneath the clavicle. You make a subcutaneous pocket. It should not be very close to the clavicle. The pacemaker itself should not hit the clavicle because that would produce pain. And what you then do also is to make a tunnel between your scalp incision and the subclavicular pocket. And finally, you place the pacemaker after joining the wires. And couple of things which should be kept in mind is that the patient will be having a lot of head and neck movements as they go about their activities of daily living. So the wires, as they are placed in the scalp, in the around the butthole, they should have a relaxation loop on both the sides. And also, as you place the pacemaker, the wire should have some loops around the pacemaker to allow for some normal head and neck movements, up and down and sideways movements to happen. If you don't have these relaxation loops, then the normal head and neck movements of the patient may put an undue mechanical stress on the implant and lead to fracture of the implant. So a couple of examples of DBS patients. So look at the typical tremor and the shuffling of gait. This is a patient on the day of DBS surgery, and there is a freezing of gait and there is tremor, and the patient is having this short shuffling steps, typical scenario of a Parkinson's disease patient in the off phase. And this is the same patient next day after DBS surgery. You see that there is no tremor and the fine movements are very good. And this patient is actually saying that he's feeling much better. And you can see that he is getting up almost by himself and he will start walking by himself without any support. So this is the very next day after a DBS surgery. Another example, this lady with a young onset Parkinson disease. So Parkinson disease, which starts before 50 years of age, we call it as a young onset Parkinson disease. This lady actually was suffering with a lot of dyskinesias and a very high dose of levodopa. And this is again on the day of DBS surgery. You can again see the short shuffling kind of a walk. And this is the same lady the next day after DBS, bilateral ST and DBS surgery. The interesting thing about this patient was that even after 3 months of a DBS procedure, she hardly needed any levodopa dose. So she had what we call as a pronounced microlesioning effect. Some of the patients after a DBS procedure will have a lot of benefit even before you switch the pacemaker on. So the explanation is that the lead itself on both the sides has created what we call as a microlesioning effect. This lady had a very pronounced microlesioning effect, and in fact, she is now 7 years after DBS, still doing very well and still on a very low dose of stimulation with the pacemaker. Now, the next video, what I would like to convey is that the just a millimeter or two of wrong placement of an electrode can produce a lot of problem for the patient. So this lady came to us. She had DBS surgery done somewhere else. And just look at what is happening to her right foot. So after DBS surgery, she is having a lot of dystonia of the right foot, which is preventing her from walking. So she had DBS surgery 4 months before coming to us and very, very disabling dystonia of the right foot. Now, what we found when we did the MRI with the lead inside, with the previous lead inside, and we created a plan for changing the position of the lead. And if you watch this video very carefully, you will see that the left side lead, which is on the left side of the screen, is medial by at least 2 millimeters. Let me play it again for you. So just look at the axial images and look at the end where the lead is. It is at least 1 or 2 millimeters medial to where it should be. So if you put the lead more medial than it what should be, and little bit medial and anterior, then you'll end up with the dystonia, stimulation-induced dystonia as a side effect of your DBS procedure. What we needed to do is just to take out the old lead and put it according to this new plan. And that is exactly what we did. And this is the video of this lady 2 days after the insertion of the lead. And you can see that the right-sided dystonia is a lot better. So she is on follow-up. She is now 9 years post this reinsertion of the lead, and she continues to do very well. Now, let's see maybe one interesting case of dystonia. Now, dystonia, like Parkinson disease, is also a very disabling disease for the patient. And this is a lady with cervical dystonia. And you can actually see that she has to hold her head to be able to see ahead and look ahead and walk. This is the pre-op video. And the same lady, this is the post 3 months DBS video showing that her walking has improved. And what we did is a GPI DBS. And in fact, this slide also shows you the kind of recording that we got. So I think I have already significantly overshot my time allotted. And I've been speaking almost for an hour, I think. I think what I should do now is to stop and we can take some questions. Just this last slide, which shows you the possible complication rates of a DBS procedure. But I think these infection rates are exceedingly high. We have not encountered this high an infection rate. But yes, the hardware complication rate can be very high if you do not pay attention to carefully handling the hardware. With this, I think I will stop and ask you if there are any questions or any kind of comments on my talk. Thank you so much.
Thanks for your detailed presentation, Professor. And firstly, I have some questions, and then I will direct the questions from participants. But before the questions, you can stop screen sharing so we can see each other. Okay. Do you use anatomical atlases for DBS targeting? And if so, which atlas do you prefer? Anatomical atlas.
Oh, sorry, which atlas?
Yes.
No, for a typical DBS procedure, actually, I do not use any atlas.
Okay.
I think atlas is more relevant for targets that you cannot actually see on the MRI.
Okay. Second question for DBS surgical planning. Is a 1.5 Tesla MRI sufficient, or is a 3 Tesla MRI necessary?
So I would prefer a 3 Tesla MRI wherever it's available because it gives you a finer level of detail. But having said that, whenever we are fusing CT and the MRI, the important thing is to make sure that the fusion is good. So there is a step in the planning station, whichever planning station that you are using, that you have to check the fusion of the CT and the MRI images. So a 3 Tesla MRI could give you a higher distortion, but if you check the fusion, that the fusion is very good, then I think 3 Tesla is superior to using a 1.5 Tesla.
Okay, thank you. And I think you use both image-based targeting and microelectrode recording. What are the main advantages and disadvantages of image-based targeting compared to microelectrode recording?
So you see, purely targeting based on the image, the problem is that whichever stereotactic system you are using and whatever images you are using, there is an end-to-end error of approximately a millimeter or so. And what I personally like to do, especially when I am doing DBS for Parkinson disease, is that having that microelectrode recording give me the typical signature of subthalamic nucleus, something which I find very valuable. It can increases my level of confidence that I am exactly where I should be. I would also say that that is very important, maybe for the first 100 or few hundred procedures that we do. Once you have refined your technique and imaging, and the entire setup is end to end very nicely laid out, and you have tested and cross checked the accuracy of your entire technique and system, then you could step away from using microelectrode and doing purely image based targeting. So I think that would be the correct way to progress. There are many institutions which don't like to use microelectrode because they say that each microelectrode pass increases the risk of hemorrhage. So while that is true, I personally, what I practice is that from 5 microelectrodes, I've come down to 3 microelectrodes now. And at least in my experience, the chance of bleeding is actually very low. It's around 1.5%.
Thank you, Professor. And Dr. Abdulkadir says that, hello, sir. First of all, thank you for your wonderful presentation. He has two questions for you. Firstly, Parkinson's disease. How exactly does deep brain stimulation reduce the neural noise within basal ganglia circuits? And is this effect purely inhibitory, or does it also help restore psychological firing patterns?
So as I said, I don't think anybody has exactly worked out the mechanism of how DBS works. Having said that, the dopamine deficiency basically produces an overactivity of the efferent loop, which is pathway is through the subthalamic nucleus. If you inhibit the subthalamic nucleus by doing ST and DPS, it restores the balance in Parkinson disease, and thereby it reduces the noise, as you call it, in the circuits.
And second question from Dr. Abdulkadir. Does the brain develop any form of dependency on the pulse generator over time? For example, does the intrinsic neural activity worsen without stimulation compared to the pre-implant baseline, or does the brain retain the benefits even when the device is turned off?
I think what actually happens is that over the stimulation retains its effect. So there was a very interesting randomized trial done in which the UPDRS motor score was calculated 5 years after a DBS procedure. And in patients who had a DBS procedure, even after 5 years, there was a significant benefit in terms of the UPDRS motor subscore. So the stimulation retains its benefit. That is the first thing. Second, the quality of life studies show that each DBS procedure adds, on an average, 11 to 13 years of quality of life to a patient's life. And regarding the dependency over time, honestly, I would not have any way to answer that question. But also to consider that we are dealing with the disease which is also progressing over time. So over the long term, over the decade or 2 decades after a DBS procedure, what is also happening is that the Parkinson disease is worsening. And what happens in the later phase of the disease is that the non-motor complications start dominating. The cognitive decline, the behavioral issues, they start dominating, and they do not respond very well, as we know, to deep brain stimulation. The point is, with deep brain stimulation, the aim is to give a better motor function to the patient. And as I just said, each DBS procedure, and that is what we counsel the patient, adds approximately 12 quality of life years to the life of the patient.
Thank you, Professor. And Dr. Ertan Sevim from our clinic says that, thank you for your excellent presentation. His question is whether this operation is effective in treating psychiatric illnesses. He asked, and you have answered.
Yes, so the psychiatric illnesses is going to become a very important indication for deep brain stimulation. And these psychiatric illnesses, which are currently already being treated with a high success rate with deep brain stimulation, are obsessive compulsive disease, treatment refractory depression, and also Tourette's syndrome. Tourette's syndrome, as you
Tourette.
know, Tourette's
Uh-huh.
syndrome.
Mm-hmm.
And it has a self-mutilation. There is obsessive compulsive component to it also. And they have some tics as well. So in the future, as I just mentioned, opioid addiction and heroin addiction may
Mm-hmm.
become important subsets of patients for whom deep brain stimulation will be effective. So there is a series from China by Professor Bomin Sun, which shows that nucleus accumbens DBS is very effective for addiction.
Thank you. And another comments from Professor Kamil Sucu. Thank you for your exceptional lecture. Is there a significant difference between the isocentric 3D C arm and the O arm for intraoperative control? Does having an O arm make things easier? I mean, compared to C arms that can take 3D images and axial sections.
I think if you have a 3D C arm or a O arm, there would hardly be any difference between them. The main advantage of the O arm is that it is networked and linked to, for example, the Medtronic stealth station. Every time you acquire an O arm image, it is automatically registered and fused to your existing stack of images. In a 3D C-arm, you would have to import these images and then it would need to go into some surgical planning station. So you really need to have these two components that are linked to each other. So it really doesn't matter if you use a O-arm or a 3D C.
Thank you. And Dr. Tony says that thank you, sir, for excellent presentation. There is a question of him. What is your opinion on sleep DBS? Is the West moving more towards the sleep DBS?
Yes, so I think that is an excellent question. And somebody has said that we are all marching slowly towards a sleep DBS. The reason is a sleep DBS is more comfortable for the patient. Uh, Patient does not have to participate, communicate, hear all the noises which are there in the operating room. Some patients really have a lot of anxiety. They don't like to hear the sound of their skull being drilled and so on. So sleep DBS is more comfortable, good for the patient. Sleep DBS is quicker. So maybe you can do more surgeries in your operating room. So maybe the surgeon is happier and the hospital is also happier. And the emerging literature in centers who do a sleep DBS is showing us that the outcome is no different. So this is also links to your first question, whether why to do microelectrode recording. Just to image guided DBS asleep, many centers are converting to that policy. My only sort of uh, point I would like to make is that whenever you are starting to do DBS, probably good to start with the classical DBS procedure and then slowly give off things which you actually think you do not need, like microelectrode recording, like having patient intraoperative evaluation of the patient. So slowly to give up the components which you think you don't need because you have done so many DBS procedures and you are very confident that you do not need these additional checkpoints for confirmation.
Thank you. And last comment from Dr. Simon. Thank you for marvelous presentation. Last question of mine. How do you assess the risk-benefit balance of DBS in elderly patients with Parkinson's disease?
I think that's an excellent question. So what I would say is after 70 years of age, we are very selective in offering DBS
Hmm.
because we are also looking at uh, For example, how much benefit will this patient get? And also, we have to look at the anesthesia risk. So the risk,
Mhm.
which includes the comorbidities, is the patient on an antiplatelet medication? Does the patient
Mhm.
have a severe heart disease or a kidney problem? So all these things have to come into the picture. And if the patient and the patient's family are motivated, they understand the risk, the patient is in good general condition and in good psychological condition as well, then I think we would have no hesitation in offering this procedure because the risks are relatively small.
Okay, thank you. And as far as I can see, there isn't any question in the chat part. Thanks again, Dr. Gupta. I give the turn to Professor Kamil Sucu for closing speech.
Uh, I want to thank you, Professor Gupta, for this excellent lecture. It opened new horizons in our eyes, and then I hope to see you in Turkey, Izmir, one day, not the distant future. And I want to send some of my colleagues, first Selin, of course, to India, to you to learn properly DBS.
Thank you very much. Thank you very much. It was a pleasure being with all of you. And thank you very much for so many interesting questions and very interested listening to my talk. It would be a pleasure to collaborate with you, to visit you, or maybe you can visit us sometime when we are doing one of these procedures. We do for movement disorders. We've done some DBS for epilepsy and also for OCD. So I look forward to a lot of interaction with your group, and
Yeah.
I hope to see you in one of the meetings very soon.
Thank you so much. If we start, maybe you can come and do here the with us the first operation or second operation. Maybe you can
I
come.
would be happy to. I would be happy to help. I would be happy to help. And before that, if you wanted to come and see one of our procedures, you are more than welcome.
Thank you. I want to
Thank
thank
you.
everyone who joined us today, this evening. Thank you.
It was a pleasure. Thank you very much. Thank you.